started. Well, actually, the server's not responding. Let me end this presentation and start mine. I'll just take a second. So I wanted to begin by just, I'll show you what I'm going to talk about. A little bit about the new administration, my department, very briefly, how I think public policy has helped us in New Mexico to address the opioid use disorder, and then where we're headed in the future. I wanted to start by just greeting you all on behalf of the governor, who found out I was going here tonight, and she wanted me to get a message to you. So raise your hand if you provide direct care to people who suffer from opioid use disorder, and keep your hands up. And then raise your hand if you support people who provide direct care. Okay. So on behalf of the governor and on behalf of myself and the Human Services Department, Behavioral Health Division, I want to thank you for that work. It's not the easiest work to do. There's challenges. It's not a kind of practice setup where you can just run through people quickly. There's surprises every day. We know how much work that takes, but we know how much value it provides. And we know that there's many, many people, probably thousands of people, New Mexicans, who are alive who would not be were it not for the work you did. So I just want to make sure you know that we know that we appreciate it, and we're going to find other ways to thank you, which I'll talk about near the end. I also just wanted to mention that under the new administration, we've got 3 outstanding health-related secretaries, Kathy Kunkel, Ellis Liu, and Brian Blaylock. Some of you worked with Brian Blaylock during the legislative session. He's a legislative machine. He got 4 bills passed that deal with issues related to children, including opiate affected children. He did more in 1 year in our state legislature than most CYFD departments do in 4 or 5 years, and it's a delight. The governor really insisted that we all work together. She does not allow silos or non-collaboration between departments. It was sort of a direct order, but it turns out we really like each other and enjoy each other's company. So a lot of those things that take more than one state department to really pull off, particularly in health, we're on the same page. These 4, I'll talk about a little bit later, but are very active in the Behavioral Health Collaborative and the oversight of it in the direction, and that's something that we haven't had at the secretary level in the past. You also may have looked at on Michelle's website during her campaign, and she had 9 healthcare policy tenets, and one of them here that I'll go over in a little bit of detail later is just to fix the broken behavioral health care system. So she's very aware of issues related to addiction and behavioral health services and how that affects with the criminal justice system. And so that is guiding some of our policy. For those of you who don't know, the Human Services Department in New Mexico serves 955,539 unique New Mexicans. So if you think about the fact that there's 2 million New Mexicans, and we're not even counting the behavioral health folks that are treated that aren't under Medicaid in these numbers. These are just out of our system. We provide over 450,000 New Mexicans a food benefit every month so that they don't go hungry. We provide 28,000 New Mexicans income support. A lot of people don't know this, but we also manage child support payments in the state to ensure that those payments, that money gets to kids from the non-custodial to the custodial parents, over almost 250,000 people. And then a lot of other really cool programs, but they have such a small number of people in them that we don't have room for them on the slide. But we really are dedicated to serving the poor in New Mexico. And as the governor said during my interview with her, my job is really to ensure that every New Mexican who's entitled to benefits gets them. And so that's the byline for our administration. That's our marching orders at HSD. That's what I think about when I wake up at night at 2 o'clock with new ideas of what we can do, is how do we get these benefits to people? And I just think it's important to say that to create a context for what we're going to talk about today. Medicaid has over 850,000 New Mexicans, almost 35%. But if you put all the programs in there, actually it's 42.5% of our population. And this is an important point. The governor is really persistent on this as well. As you know, it's great to provide coverage for everybody. If nobody can get an appointment, if nobody can get treatment, you actually haven't done anything. And so a lot of what I'm going to talk about tonight is a refocus on our provider network, how we can rebuild that, how we can support that, how we can encourage growth, how we can expand services, how you can help us do that. Another thing that's really important in New Mexico are those red bars there, and that is the expansion population. The Affordable Care Act brought over 250,000 new individuals into Medicaid who were previously uninsured. You may not know it, but it brought $10 billion of money into the state to support health care. You may not know this, but 86% of the new jobs in New Mexico between 2014 and 2017, all new jobs, were in health care, and we're motivated by this. And so Medicaid actually, and we went to the Albuquerque Journal and even convinced them, they actually had an editorial to support the Medicaid budget. That's never going to happen again, but they said fully support the Medicaid budget to support providers to help them care for folks. And so that's a great deal. This average per member per month cost in Centennial Care has been flat, and we realize now that that's something that needs to be changed. One last thing, and I like to brag about this because it's like the only important research paper I've ever written in my entire life, but it's one of those bucket list things. If you're a physician, getting something in the New England Journal is, then you can just retire. But this is about the convening power of the Human Services Department, because we have $7 billion flowing through our department. We have the bill, and we touch every provider and half of all New Mexicans. We have the ability to pull together people to do things new. And just very briefly, in 2014, we had treated 150 people for hepatitis C. And we're up, it looks like, to 1,400 in 2018. We'll have final data in the soon. But we pulled together the MCOs. We changed the incentives. We changed the way people thought about it. We came up with one way to get an authorization for those of you who have to do that. And you can see the authorization rate, which is the line in 2014, was 45%. And now that was 45% of providers who sent in an authorization request for Hep C drugs got a yes, and now it's 95%. So we get that we can bring people together. We get that we can change the financial incentives. We get that we can provide technical assistance and support to help people do things in new ways. And that's a lot of what we're going to be about. Others will probably talk about our collaborative hubs, and it's complicated in New Mexico. There's a lot of folks, even in the government, DOH, CYFD, aging, HSD are all involved, but there's, this is just a representation. There are many, many people throughout the state that have their own organizations. I've already met a bunch of you. Thank you again for doing this work. And you've had some great results. MAT treatment, more than double our goal. Recovery support, 5 times our goal. Training to improve the workforce, 10 times the goal. And the only places we fell a little bit behind was in naloxone distribution, and folks are working hard on that as well. So we know that when we come together, we can do some things. Now, I'm optimistic about this issue because we're starting to see good results. Wayne mentioned we were number 1 in drug overdose deaths for many, many years. And we are now, as of 2017 anyway, down to number 17 nationally. And, we have a lot of legislation that has been passed. And this is a really interesting example. Like I didn't really appreciate the degree to which New Mexico had acted in the public policy arena around opioid use disorder. And I don't normally like the idea of government making everything happen. I like the idea of folks in practice innovating as well. But I think that the public policy that's happened over the past 6 years has really supported what we're trying to do for our patients. And so allowing naloxone to be dispensed by pharmacists, law enforcement folks, no more traditional prescriptions. I'm, as a practitioner, I have the great opportunity to review the PMP database every 3 months. As you know, it's moved up. It's now the number 3 complaint of doctors, with number 1 being, of course, the electronic medical record, and 2 being managed care organizations, and now the PMP. But I think it's saving lives. It's certainly informed me about things I didn't know about my patients. It's been a huge driver for me to no longer dually prescribe benzodiazepines and opioids. I'm a geriatrician, so, my folks just fall down and whack their head and break their bones and things like that. So I have a lot of compelling reasons not to do it. But that's a public policy change that is changing provider behavior and helping us. Other things, and I'm going back now, but, all of us get 5 hours of pain management training every 3 years in order to maintain our licenses. The Pain Management Advisory Council has done a lot of great work with cooperation with the DOH to do that. I talked about the Medicaid expansion, getting people coverage and getting them access, bringing that $10 billion of federal money into New Mexico has been huge. And Wayne has more detailed data, but there was a significant increase in the number of people treated as a result of that expansion population. We're one of only 16 states. Again, another policy approach that suspend Medicaid when someone's in jail, and we immediately restart it. We're making it much easier to get that person immediate coverage when they leave the jail. And now we have to figure out how to get them a ride to the pharmacy to get their antipsychotic medication so they can start it, or they can continue it immediately. And we're working on that. And then I'll say a little bit more about this, but we have no prior authorization requirements anymore for MAT. We believe it is the evidence-based way of treating opioid use disorder. We don't think abstinence is a strongly evidence-based or an evidence-based treatment. And so we're fully behind that and fully supporting it. And you can see after we removed those auth requirements, it's more the treatment in the expansion population anyway has more than doubled. We've got grants. CYFD is doing a lot of work. And I'm not going to go read all the details of the slides because I wanted to leave a couple minutes for questions. New legislation about education and methadone clinics. I don't know what happened, whether the governor signed the bill about, I think actually the bill did not make it through, but we'll work on that next year for ensuring that folks get naloxone prescriptions at the time they start on longer-term opioids. But, police officers carry these, ambulance drivers carry them, they can administer them, and so I think we're making a lot of progress there. And so as a result of all that we've done in public policy and the decline we've seen from number 1, we're number 1 down to number 17, we're recognized as one of only 2 states in the whole country that have implemented these 6 key opioid policy actions that have been shown to help save lives. And so that's one thing that's really exciting for me, because I brought a lot of medical background to this new role, but I'm really seeing the way that we can work together to get these public policy initiatives passed, to make it much easier for people to get access to treatment and get reversal and to improve. The other thing I should have said at the beginning is you saw Kathy Kunkel up there. She's the one among the 4 health secretaries that really is the lead person in opioid use disorder, and this is one of our preliminary priorities anyway for our behavioral health collaborative. So I'm kind of here on her behalf. The health secretaries figured out, after we had all spent 5 hours in a committee hearing, I think it was a Senate committee hearing, waiting to each speak for a minute, that we could speak on each other's behalf, so we're all authorized to. I can say anything I want about CYFD, and Brian claims that he'll back me up. But I'm kind of here in a way on the DOH's behalf tonight to talk about these things, because they've done a lot. So now going back to what are we going to do next? These are some, not all, of the governor's policy initiatives. And they've morphed a teeny bit, but not too much. And so some of the things that are relevant to you that I wanted to highlight tonight in addition to the whole right side of this slide, which is really geared at fixing the broken behavioral health care system. And if the governor were, so I've been in about 5 or 6 public events with the governor, and she absolutely cannot resist pointing me out to the audience. Have you been at one of these? Said, see that guy there? That's David Scrase. He's in charge of rebuilding behavioral health in New Mexico. And and we've had great progress already under Wayne's leadership, but other things include this highlighting of maximizing federal funding for Medicaid. I mean, I am overwhelmed just with emails from federal agencies who want to give us money to deal with the opioid use disorder. And, it's a little ironic that alcohol-related deaths are way, way, way higher in our state than opioid deaths, but, we're going to take whatever help we can get and get that focused. There's a new bill that was signed, a prior auth bill that reduces the burden to providers that I think is exciting, but trying to take all that paperwork away so you all can spend time with your patients, your clients is really important to me as well. Recruiting and retaining more healthcare providers and paying them fairly. And then you're going to hear on the right side of the slide a lot more about opioid use tonight. You're going to hear Andy's going to get up and tell you about ACEs and how we're getting ready to address those more. And I think Andy feels, and I can say this too, we both have a great partner in Brian Blaylock, our CYFD secretary, who has just amazing experience and background and passion and enthusiasm. So specific things that already are in the works is you're going to hear news soon. This is like the first public talking about this, of significant increases in Medicaid rates for E&M codes, evaluation and management codes. The things you do when you spend time with patients face to face. And we're also going to introduce payment. We're working on introducing payment so that when you participate in ECHO as a provider and present a case, you'll be reimbursed by Medicaid for that as well. You can burst into wild applause anytime you want, yeah. If you knew what we were up to, you would have applauded more for the rates, but that's fine. If you like ECHO, that's good to know. We've already put into place the potential for over $33 million in new programs and services within Medicaid, and we're now busy getting out to the provider network and letting you know what those are and how to bill for those and how to get paid for those. And I think we're also, in that vein, looking really hard at how can we provide more actual practice and technical support to you all so that when new things are available, new funding is available, new programs are available, like being very proactive, like having a provider services kind of group that can come out and educate our network, all you folks who provide this great care, so you can take advantage of those things immediately and not just wait for a year or two until they roll your way. I'm puzzled with, I think we've got more capacity in our network than, I think we have a lot of potential capacity in the network. When I look at the data that Wayne shares with me, that only 23% of our buprenorphine certified providers treat 10 or more patients a year. How can HSD help you all expand that capacity? What do we need to do? Obviously, paying you a little bit more is going to help, but what else can we do to expand, to have that? I have friends who prescribe buprenorphine. I know that it can be a time-consuming initiative. Are there ways in groups or other ways to handle this like we do with diabetes? So we're really open to your suggestions about how to increase the average number of people. And I mentioned earlier that substance use disorders is one of our top 3 draft, don't quote me on this yet, draft priorities for the Behavioral Health Collaborative, and there is intense ongoing involvement of the health secretaries in this too. And when you have folks involved at the secretary level and really committed, you can get a lot more to happen across all the different departments. And so I'm pretty optimistic about that as well. So just briefly to review, I'm going to take some questions here in a minute, but does Medicaid have any restrictions on prescriptions for medication-assisted treatment? No, we don't. Okay, there are none. We have none. Okay, everybody? So that's done. And then the last thing, I just think this is really interesting. And I had this incredibly ironic moment last week. On Tuesday night, I'd read how Purdue Pharma had settled $270 million in a lawsuit with the state of Oklahoma for the damage that their opioids had done to their population. And I just read it. I didn't read the article. I read the headline, basically. And the next morning, we met with basically a lobbyist who's working for the giant pharma industry, and they're coming to New Mexico with a budget for some grants to help with the opioid epidemic. And so she kind of gave this long description, and I'm not the most patient person, and so I waited as long as I could, maybe 10 minutes. I sort of interrupted her, and I just said, so can you tell me what your budget is for this here in New Mexico? And she said $150,000. And I said, well, what would you estimate the cost of the damage of opioids in our state would be? And she said, well, I don't know. I mean, I'd have no way of knowing that. And I said, well, they figured it out next door in Oklahoma. You know, they agreed, Purdue Pharma and Oklahoma agreed that cost was $270 million. And I felt really sorry for this lady because she knew she was not in a very good situation. And then when we talked further, it turned out that the maximum grant award they could really offer was $15,000. And so, but we did figure out that for $15,000, folks like you might be able to get help writing a grant for more money from SAMHSA or something like that. So that was the only thing we could think of. But I believe that this has the potential to be the next tobacco settlement, and that we have the potential across the United States to create an accountability system that brings the necessary funding into the state to deal with this and to help us through this. So that's.
David, would you share your metaphor that you shared with her? Because I thought it was wonderful.
Oh yeah, sorry. So those of you who already know me know I can be sarcastic. But when we got to the 270 million versus the 150,000, I said, you know, it's kind of like flying a helicopter into a war zone where there are people with missing limbs and medics running all over and they're under fire, and landing your helicopter and reaching out and handing someone a Band-Aid and taking back off. So I think we're going to need a lot more. But whatever we do, we're going to build on the foundation that you've already put in place, that you've already laid, and that you're already making happen here in the state. And based on the amount of time I had allotted, I think I've got like 5 or 6 minutes for a couple questions, and I'm happy to really entertain any question at all. Yeah. So wondering if nurse practitioners have to go through an extensive process to get
the X waiver the X waiver for prescribing buprenorphine. It's 15. Yeah. Is there any sign of that decreasing? Because that's a much bigger commitment than a lot of people are willing to make.
So one thing I like about the Q&A session is I have absolutely no problem saying I don't know. I don't want to put Wayne on the spot, but that's the kind of feedback we're open to. It's a federal requirement? Oh, okay. So, sorry. Next time Heinrich is in town, you know, or one of our national legislators, let him know. But, you know, they're asking for feedback from us all the time, and I can feedback that back. I guess the question, in order to make a case, we would have to be able to show somehow that if we lowered that treatment requirement, that would result in many more nurse practitioners taking the training, and that would result in many more people getting the treatment. But yeah, go ahead.
I've been involved in MAT work in a couple states, including here. And one thing that I seem to see as a unifying feature is there's far too much regulatory influence, which just stifles a lot of innovation, and by consequence, I think a lot of potential outreach. I'm wondering if the HSD has any ability to influence certain agencies in state, such as DEA and maybe to less extent SOTA, to be more open to pilot projects that are endorsed by the national agencies but have not been implemented at all here? And if so, how would you kind of move forward with granting funding for these types of innovative approaches?
Yeah, you mentioned DEA, which is a federal agency. I think one of the things we want to do as part of this rebuilding effort and helping practitioners build for things and all is to get the kind of feedback about what your priorities really are. And yeah, if there's 3 or 4 things that you all agree would really make a difference. In the end, it has to all trace back to people treated, the number of people treated, the number of lives saved, which we can help you with the math on that. But I'm all for innovation. I'm one of my little jokes is I want to try to bring as many free market business principles to state government as I can get away with. And we have a Medicaid system actually that is a competitive model. We have 3 managed care companies. It has dramatically lowered costs of administration. And so, yeah, I had a previous career as a healthcare executive and then was at the university, so I kind of have a feet in a lot of different worlds, but very open. Yeah, anything you guys want to do that you think is innovative that will result in treating more people, saving more lives, let us know. Yeah.
You mentioned the lack of barriers by prior authorization to accessing buprenorphine. I think that's been great for oral buprenorphine. I was wondering if you have any knowledge or updates on long-acting injectable buprenorphine and its possibility of being included in those same limited barriers or limited PA requirements that we have for Medicaid patients for oral buprenorphine.
I have a text from my Medicaid director on this subject because I thought someone was going to ask. Did you know about that, Wayne? Yes. Okay, do you want to elaborate?
I think in large part it's a cost-benefit analysis. And how much more is it going to cost us? I think there are environments such as correctional settings where there's a lot of concerns about contraband, et cetera, where the injectables make a lot of sense. But in addition to always looking at the benefits, we also always have to have the cost equation as part of that, and we haven't done that work yet, but we will.
It says here, and that was on my slide, that we've instructed the MCOs not to have prior authorization for any formulation of buprenorphine used for the opioid use disorder treatment. So if long-acting or injectable was, it would seem like that's covered. But I can take that back and find out. Great point. It is a challenge. Like if the injectable buprenorphine was, it's like Hep C. There was an editorial in the Albuquerque Journal 3 years ago, like, why are we paying to treat people in prison for Hep C? And we wrote an editorial, and myself and a couple other folks, and said, if this costs $300 for the treatment, like it does in Egypt, no one would be writing editorials about this. It's, at the time it cost $84,000 in the United States versus $300 elsewhere. So it's a challenge when new drugs come out that cost 10 times as much, that even if the efficacy is 10% better, when you do the math on that and you're spending, in Medicaid. So in Medicaid, if we spend $1 more per month on every Medicaid member, does anybody know how much that is in a year? Do you know how much that would be? It's $10 million a year. So even little tiny changes to cost of things in Medicaid are dramatically magnified. So we do our best. And I think where you all can come in is helping us find that evidence, helping us show that the cost benefit makes it worth it. And we're happy to make that case. But we sometimes have to explain these things to the legislature, and so they have to be real simple, and it has to be completely and totally focused on the benefit to the folks, to New Mexicans. If you make the argument this will be so much better for providers, that's okay, but it's really about New Mexicans and the people we serve. Yeah.
So I've often been struck that there's a requirement to understand or do CME training in pain management. We all know there's a huge overlap between pain and addiction, and where's the line? It occurs to me that there are so many people prescribing still. There's so many people who prescribe opioids. Why not require people who prescribe opioids to know how to get people off opioids?
Yeah, I don't know about the training you go to, but I've been through, 3 cycles of this, or I think it's 2 cycles of this. And plus I get a lot of, when I was at the university, I got a lot of extra training on it. But of the 10 hours of training I've taken, about 9.5 hours was really, of pain management training was about opioids and how to treat pain and how to get people off. So at least in my training, and maybe that's unique, that's been the focus.
Encouragement for people to get training to use buprenorphine, to use medically assisted treatment. I mean, I'm a psychiatrist and an addiction specialist, and I've had, I don't know how many patients over the years who have come to me to get off the pain medications they get from their pain doctor. And that
Oh, I
just
see
seems
what you're saying.
ridiculous.
So kind of what you're saying, I mean, this might be an extreme extrapolation of what you're saying, but what you might be saying is in order to prescribe opioids in New Mexico, you also have to take the training and be able to prescribe buprenorphine.
Yeah.
There's a really interesting New England Journal of Medicine piece that was done by Joanna Katzman, George Commercy, and one other person about a year ago. Dr. Dewey, there you go. Sorry. And they kind of they sort of cautioned all of us about the pendulum. You know, you would have to talk to me a long time to get me to support what I just talked about of, in order to prescribe an opioid, I have to be buprenorphine certified, because I think that my opinion is that the main thing that would do would be to have 90% of doctors stop prescribing opioids. And maybe from your perspective that would be a good thing, but as a geriatrician and when I think about the people I treat for pain, I don't think it would be a good thing. So I think the unintended consequence would do a lot more harm, again, to the people of New Mexico than the potential benefit.
I think it's worth more discussion.
Okay.
Just a quick reminder, please, if you have a question now and later in the evening, please remember to raise your hand so we can bring a microphone to you. Just make sure all of us can hear your
My time is up too, so I'm going to step down. We really want to know your ideas. We really want to hear. We really want more in the way of intervention. We really want to know what your collective priorities are for public policy interventions. I'm interested in your individual ones, but ultimately what we can act on and what we can make changes on are those things that, as a group, you all believe are priorities. So stay in touch. Thank you very much.